Skills Lab video. Newborn assessment, admission. The admission newborn assessment is completed within 1 hour of the baby being born in the labor and delivery unit. This newborn assessment is a more in-depth assessment in each areas of the 10-point newborn focused assessment mnemonic. This mnemonic is not as friendly as the postpartum mnemonic and will require a bit more effort to memorize, but it is a great tool to help you focus and organize your newborn assessment. We will be using the mnemonic Ashlegasar, and it stands for A, appearance or general appearance, and this looks at the physical activity, muscle tone, posture, and the level of consciousness of the newborn. S, skin, and this looks at the skin color, texture, the nails, and any rashes that the newborn may have. H, head and neck, and this will look at the shape of the head, the soft spots or the fontanelles on the baby's skull. We will also assess the face and look at the eyes, ears, nose, and mouth, and including the hard and the soft palate. And this also looks at the bones across the upper chest or the clavicles. L, lungs. This looks at the sound the baby makes when he or she is breathing and also looking at breathing pattern. H, heart and peripheral pulses. This looks at heart sounds and assesses for heart murmurs and also looks at both the presence of brachial and femoral pulses. A, abdomen. This will look at any masses or hernias and listen to bowel sounds. G, genitals and anus. This checks that the baby has an open passageway for both urine and stool. And this will also assess for the appropriate anatomical genitalia for the identified gender of the newborn. A, arms and legs. This checks the baby's movement and development, making sure that we have 10 fingers and 10 toes. S, spine. This checks for the alignment of the spine and any abnormalities or anomalies that may have developed. And R, reflexes, and this will check for neurological development. The first steps in the procedure is to wash your hands before walking into the room and or before performing the assessment. You want to introduce yourself to the parents of the newborn and explain that you will be performing a newborn assessment and include what you will be assessing and why you will be assessing those areas. Place the newborn on a flat surface at a level appropriate for you to use good body mechanics. Ideally, this assessment should be performed under the radiant warmer so not to allow the newborn to lose heat quickly. Since we're assessing a newborn that most likely has not had his or her bath, we need to wash our hands and apply gloves since the newborn is most likely covered in blood and body fluids, and we need to observe appropriate infection control. Unwrap the newborn and check to see if the ID bands on the baby match those that the parents have. We'll start our assessment first by assessing vital signs. The first one will be respirations. Since the newborn is most likely quiet, we can observe the respirations while the newborn is exposed by watching the rise and fall of the newborn's abdomen. The normal rate is 30 to 60 breaths per minute, and it will be irregular in nature. Because they are so irregular, you can assess the respirations in one of 3 ways. You may observe the rise and fall of the abdomen. You may palpate the rise and fall of the abdomen by placing your hand over the belly and feeling that rise and fall. Or you may auscultate the lung sounds and count the inspiration and expiration. We'll next assess our apical pulse. We need to count for 1 full minute, and the normal range is going to be between 110 and 160 beats per minute. If the baby is quiet, it can go as low as 90 beats per minute. And if the baby is crying and very active, it can go as high as 180 beats per minute. Next is the temperature. It is no longer recommended to take the initial temperature rectally, as it can cause more trauma to the rectal mucosa. Instead, the recommendation is now to take it axillary. It needs to be recorded and gathered in Celsius instead of Fahrenheit. The normal range is 36.5 to 37.6 degrees Celsius. Blood pressure is not done on a newborn admission and will only be ordered if the newborn is admitted into the intensive care nursery. We next want to get the weight of the baby. The normal weight is 25,000 to 4,000 grams, or 5 pounds 8 ounces to 8 pounds 8 ounces. If the newborn is too small, or less than 2,500 grams, then the risk for complications is present. And if the newborn is too large or above 4,000 grams, then we're also looking for possible complications. The normal length for a newborn is 48 to 52 centimeters, or 18 to 22 inches. Since the newborn is exposed, now is the perfect time to assess the general appearance. So we're going to be looking at the physical activity, muscle tone, posture, and level of consciousness. It is the ideal time also to assess the skin, so looking at skin color and birthmarks such as Mongolian spots, which are very common and normally found on the coccyx, but it can also be found on the lower back, on the arms, on the legs. So we want to be inspecting the whole entire skin to see if we do see any birthmarks. And it could be birthmarks such as venous flemmis or venous vessulosas. And there's other birthmarks, so please refer back to your book so that you can see images of these birthmarks and be able to better identify them when you see them in person. This can be found in your textbook on page 681 to 682. Since we haven't completed all of our measurements, now is the perfect time to do so. We're going to start with the head circumference. At birth, the circumference of the newborn's head is 32 to 37 centimeters, or 12.5 to 14.5 inches. For accurate measurement, the nurse places the tape over the most prominent part of the occiput and brings it to just above the eyebrows. The circumference of the newborn's head is approximately 2 centimeters greater than the circumference of the newborn's chest. The average circumference of the chest at birth is 32 centimeters, or 12.5 inches, and it ranges from 30 to 35 centimeters, or 12 to 14 inches. The chest measurement should be taken with the tape measure at the lowest edge of the scapula and brought around the anterior, directly over the nipple line. The abdominal circumference is measured by placing the measuring tape around the newborn's abdomen at the level of the umbilicus, with the bottom edge of the tape at the top edge of the umbilicus, and is usually the same size as the chest. When assessing the head, we're looking for molding, which is overriding of the cranial bones during the labor and birth. This is a normal finding, and we just want to see if it's present or not. You should also be assessing for the presence of caput cicindinium and cephalhematoma. Those are both accumulation of either fluid or blood underneath the skin, and that is usually reabsorbed within the body within the next couple of days. You're next assessing for the fontanelles, which are the soft spots on the baby's head. The anterior fontanelle is a diamond shape, and it is 3 to 4 centimeters long to 2 to 3 centimeters wide. It closes at 18 months of age. The posterior fontanelle is a triangular shape, and it's 0.5 centimeters by 1 centimeter, and that will close 8 to 12 weeks after the birth. We're also assessing if the fontanelles are flat, bulging, or sunken. Flat is the ideal finding. Bulging could indicate increased intracranial pressure, and sunken can indicate dehydration. We next inspect the face by looking at symmetry. We're looking at eyes, nose, mouth, and ears, and also the neck while we're assessing the face. The eyes can be bluish slightly grayish in color, or they may be brown. The pupils are usually equal and reactive to light, and that's going to be tested by the pediatrician. The blink reflex is present. The sclera is a bluish white in color, and it's very normal to see the eyes a little bit more edematous immediately after the delivery. We should be assessing the neck to see if there's any folds or skin folds that are restricting neck movement. When assessing the eyes, we're looking at its position with respect to the ears. Now, the eyes and the ears should be aligned. That would mean the slit of the eye to the top of the ear. If the ears are slightly lower set, then it can indicate Down syndrome, as it is one of the classic physical features. When assessing the ears, we should be looking that the ears are well formed. Recoil of the folds are usually present, and we want to make sure that it is in a straight line with the canthus of the eye. When assessing the nose, we're looking for patency of the nares, that there's no discharge coming from the nose. Sneezing is common and normal in newborns, and as we're assessing the nose, we should be blocking one nair and seeing if there's any grunting, flaring, or retracting, and blocking the other nair and seeing if there's also any grunting, flaring, and retracting, as those can be indications of respiratory distress. When assessing the mouth, we should be placing a gloved finger inside the newborn's mouth, and we're assessing for the hard and the soft palate to make sure that they're both intact, and assessing the presence of the sucking reflex. As we're progressing down the face, we've already assessed the neck, and now we're going to be assessing the clavicles. What we're looking for is to see if the clavicles are broken. So if they are, you're going to feel lumps and grating sensation or crepitus during movement or as we're assessing. We are also paying attention to see if the newborn is not moving one side more than the other, as this could be an indication that the clavicles are broken or that there is some damage to the nerve plexus. As we continue assessing the chest, we will notice that the chest is going to be barrel shaped. We're also assessing for symmetric expansion of the chest with inspiration and expiration. If we see that one side is expanding more than the other, we can think about a lung prolapse. We're also listening to the breath sounds and the lung sounds at this point if you haven't done so already. We're now inspecting the nipples, that there's only 2 and not 3 or 4. If there are multiple nipples, they would be mimicking the placement of a cat or a dog, as we are all mammals. So the most common area to find would not be from left to right, but from up and down. So underneath the armpit, down underneath the nipple itself. We next move to the abdomen. Here we're assessing the shape of the abdomen, making sure that there are no masses palpable. We're also auscultating bowel sounds. Now, your book says to auscultate in all 4 quadrants, but with the stethoscope, it's going to be hard to get all 4 quadrants since that area is so small. So 2 quadrants is sufficient. And all we're assessing for is the presence of bowel sounds, so we don't have to determine if they're hypoactive or hyperactive. Now, it is normal for bowel sounds to take up to an hour to be heard, but if you do not hear bowel sounds on your initial assessment, go back within an hour and reassess to identify that they are present. While at the abdomen, we should be assessing the umbilical cord. It should be white and gelatinous, and there should be 2 arteries and 1 vein. The cord should be clamped and no oozing or bleeding from it. We're next assessing the genital areas and determining if the sex that has been determined on the chart is the physical sex that we do see. Now, if we have a male, we're going to be assessing the scrotum. The scrotum should be pendulous with good rugae. The testes should both be descended, so we're palpating the scrotum to identify and palpate the 2 descending testes. If they're not descended, then the risk for infertility may be higher, and we need to make sure that we're passing that information on to the pediatrician. You're visually inspecting the penis also and making sure that the tip of the urinary meatus is at the tip of the penis and there is no hypospadias, which would be when the Urinary meatus is off to the side or underneath the tip of the penis. For a female, we're assessing the labias majora and minora. So the labia minora is usually covered with vernix caseosa and smegma in the creases, and the labia majora is covering the minora and the clitoris. It is normal to see some blood-tinged mucus discharge from the labia, and this is called pseudomenstruation. It is caused by elevated maternal hormones, and it usually disappears in a couple of days. Our assessment next moves to the spine, and we're assessing for the straightness of the spine and also assessing the base of that spine for dermal sinus or pilonidal dimple. This dimple, which is found at the base of the spine, is normal to find, but we're trying to identify that it has an end to it, that it doesn't burrow into the spinal canal, as this could be an indication of spinal bifida. We're also inspecting the patency of the anus by observing it winking at you. You cannot assume that the anus is patent just by identifying that the newborn has defecated, because they can have a bowel movement through a fistula within the vaginal area. So it's very important to visualize this area. If the anus is not patent, it is sometimes associated with other cardiac problems. And this is because the cardiac system and the lower GI system develop at the same time in utero. So if we identify that the newborn has an unpatent anus, we need to let the physician know so they can further do follow-up assessments. If you were like me and forgot to assess your brachial pulses when assessing the heart, and now realized that by reaching your femoral pulses, now's the perfect time to assess both. We are next assessing arms and legs of the newborn, and we're making sure that the newborn has 10 fingers and 10 toes, no extra digits, and no webbing of the fingers and toes. Last but not least, we're assessing newborn reflexes. The first reflex we'll assess is the Moro reflex or the startle reflex. It's elicited when the newborn is startled by loud noise or lifted slightly and then suddenly lowered. In response, the newborn straightens the arms and hands outwards while the knees flex. The next reflex is the Babinski reflex. It's initiated by stroking the sole of the newborn's foot from the heel up the side of the big toe and then slide the finger towards the pinky. You should see the toes curl outwards, and that is a normal finding. The next assessment is the Palmar grasp reflex. It's initiated by stimulating the newborn's palm with finger or an object, and the newborn grabs and holds the finger. The plantar grasp is similar, but instead of placing your finger in the newborn's hand, you're placing your finger underneath the toes, and the toes will curl up around your finger. We'll next assess the stepping reflex. When the newborn is held upright with one foot touching a flat surface, the newborn puts one foot in front of the other as if they're walking. This reflex is more pronounced at birth and is lost at 4 to 8 weeks after birth. We next want to try and initiate the rooting reflex. So the rooting reflex is initiated when the side of the newborn's mouth or cheek is touched. And in response, the newborn is going to turn their head towards the side that you are stroking them, and they're going to open their lips to suck. Now, this is going to be more pronounced if the newborn has not fed recently. We can then also evaluate the sucking reflex. So the sucking reflex is initiated when an object is placed in the newborn's mouth or anything touches the lips. This reflex disappears by 12 months. So we're talking about the involuntary ability to suck. The tonic neck reflex, often called the fencer position or the fencing reflex. This is when the newborn is in a supine position and the head is turned to one side. In response, the extremities on that same side are going to straighten and the extremities on the opposite side are going to flex. This reflex may not be present during the early newborn period, but once it appears, it persists till about 3 months of age. You now have all the information needed to be able to perform an admission newborn assessment. If you have any questions, please make sure that you write them down and bring them with you during our first skills lab during week 1.